Hello, everybody. Welcome back to Health Record Systems and Issues. This is lesson 7 of the semester. We're rolling right along, and we are going to continue. This is part 2 of health record content and documentation. Next slide. Now, as we continue this, I'm going to, as you can see, there are quite a few slides. I'm going to see how far we can get and how long my voice holds up. Okay? Now, this should help with the assignment where you are doing the forms case studies. When we're talking about documentation, I want you to remember that this is okay, little sound problem there. I want you to think about the health record and the documentation and how important it is, as we've already discussed in previous lessons. I also want you to think of it as a recording of the pertinent healthcare findings, the interventions and responses to treatment, and it's also a business record and a form of communication among caregivers. It allows for the telling and retelling of events. So it's kind of a story, okay? It's the story of what happened while this patient was in our care. Next slide. It also describes those principles and codes and beliefs and guidelines and regulations that guide healthcare documentation. And whenever you are completing the CFR or have completed maybe already the CFR assignment, where you are looking at the Federal Register, you will see that there are a lot of different things that come into play in documentation requirement. You're not just throwing in whatever you feel is relevant, but there are also certain standards and regulations and guidelines that have to be followed. It also dictates how healthcare providers should document the treatment and services within the record. It's a set of principles, codes and beliefs, guidelines and regulations that have been vetted and agreed upon by individuals or a group of individuals. Maybe it's the professional organization for a certain specialty, or the medical records committee at the hospital. You see where I'm going with this? And they are evaluated conformance with a generally accepted rule. So we do follow up to make sure that whatever has been agreed upon is being followed, and if it's not, we keep records of that, and possibly it could be a training issue, or perhaps we need to look at changing our policies, but there should be some form of follow-up. Maybe disciplinary action might be necessary. The documentation standards for electronic health record, the EHR, and paper-based records are typically kind of the same when it comes to basic documentation standards. We are talking about the basics. Some EHR technologies present challenges related to documentation standards, and those have to be worked out. There is also potential medical necessity issues as well that can contribute to the commission of fraud. I apologize if you kind of hear a little thunder and different things in the background. It's storming right now. Talking about the standards, they have really grown in complexity and detail over time. Remember how we started out talking about the history of the health record, right? And that documentation, and how we went from little to no documentation to what we have today that has progressed over time. But the care of the patient has also become more complex and detailed over time. So it's evolving with the profession. It focuses on patient care quality, the appropriate reimbursement. Patient care is always first, but if we don't get the appropriate reimbursement, that means we'll all be out of a paycheck, right? But the most important is always patient care, quality patient care. And of course, the prevention of fraud and abuse. You have to have that documentation. If it's not documented, it didn't happen. But we also want to make sure that it was documented accurately and is a true picture of what that patient's stay entailed. Documentation standards vary on the type of health record. You've got different types of environments, so that we have already seen that can kind of change the requirements when it comes to documentation. There are also multiple sources of documentation standards. We have insurance companies or payers that require certain things to be documented in a certain format sometimes. Government regulatory agencies also come into play. Licensing boards, accrediting bodies, facility policies and procedures, and then something we've not really talked about before is medical staff bylaws. And we'll talk more about those in a little bit. So let's take a closer look at the goals of documentation standards, and then we're going to get into more and more detail. Okay? So we're digging deeper. The goals of documentation standards are to ensure the complete health record and accurately reflect that it accurately reflects the treatment provided to the patient. We want to provide overall inherent level of acceptable quality, right? Quality of care. And then we want to drive the appropriate reimbursement through accurate code capture. Medical staff bylaws. These are the standards of governing the practice of the medical staff members. So let's just take a hospital XYZ, and they have, let's say, 50 physicians on their medical staff in varying specialties. Okay? So they are the medical staff members, and the medical staff bylaws are what they agree to follow at that facility. They're voted on by the organized medical staff and the medical staff executive committee. Okay, and the executive committee consists of different members of the leadership, and also the chief medical officer. And the members can vary from facility to facility. Whenever I was a health information management director, I was a member of that executive committee when it would meet, because I was over health records, and I would bring any issues to the forefront and get those on the agenda. And if we were having documentation problems, those would be presented on the agenda. If we had any type of delinquencies where a member of the medical staff did not meet the timeline requirements for documentation or signing off on orders, any kind of those types of issues were put on the agenda and discussed at that meeting. It's also approved by the facility's board of directors, and it's used to enforce quality of care. The licensure organization is discussed. Accrediting and licensure organizations, as well as federal and state regulatory agencies, mandate the content of the bylaws. Okay? And yes, they are either printed. Most facilities have a printed copy of the medical staff bylaws, and they issue those when someone gets privileges at their facility, so that they know what they are to follow. And then the medical staff bylaws will vary slightly from one organization to another, depending on their requirements. For example, one facility, which I believe the Joint Commission says that all verbal orders must be signed off by the physician. They have to sign it and confirm that, yes, they did order this, either in writing by signing their signature and credentials, or their electronic signature if they are using electronic health records. Okay. Now, the Joint Commission allows 30 days, right, for them to get that complete. However, That's the maximum they allow. However, if your medical staff bylaws say that they are only allowed 7 days or 14 days to get those records complete, then that's what you are held accountable to when they come and do a site visit and survey your facility. Okay? So they take whichever one is the stricter, if that makes sense. Okay? Now, so again, one facility might say 7 days, one facility might say the 30 days. So it will vary slightly from one organization to another, but we know that the organization is going to be held to that 30 days or less at the minimum, right? Okay. So the medical staff is a group of physicians and non-physician providers who have privileges to practice medicine at a particular healthcare organization. They may or may not be employed by the healthcare organization, which really gets a little bit confusing, but if the physician is actually on the payroll of that healthcare organization, they have privileges, and they can also have someone who has privileges to admit patients, to perform surgery, and that type of thing that the hospital does not pay to be on staff. You know, it could be specialists. Some, the ones that are actually on staff are typically called a hospitalist. And those used to be not very common, but they are becoming more common to have a physician on staff to see the patients and then whatever specialist coming in. That way the billing is a little more organized, I would think. I don't know. I would think. But anyway, so there is a difference there. They may or may not be employed by the healthcare organization. Medical staff are subject to the medical staff bylaws, whether they are employed or by the healthcare organization or not. They can be employed there or not employed there. If they have the privilege to act as a medical professional at that healthcare organization, then they have to follow the medical staff bylaws. And I hope that makes sense. If it doesn't, contact me and I'll try to explain a little bit better. Okay? Medical staff privileges are specific services and procedures that the medical staff member is deemed qualified to perform at a particular healthcare organization. For instance, a plastic surgeon has to have specific privileges in order to perform certain procedures. A family practice physician, for example, would not typically have privileges to perform plastic surgery unless he has had specialized training for that and obtains approval for those privileges at that facility. Okay? So privileges are what they can and cannot do. Okay? They might be able to perform certain surgical procedures, but another physician may not be able to. You see what I'm saying? It outlines, it's kind of like your job qualifications, and they have to provide that proof and documentation that can be verified so that we know that they are actually um, trained to perform those procedures. You would not want someone um, in housekeeping or clerical staff or a nurse performing heart surgery, right? So we have to document that and make sure that they are qualified to perform those procedures. Okay, so you understand privileges now, I hope. Accreditation. Accreditation, we've already talked about as being a voluntary process. It's a periodical evaluation of the quality of the entity's work against pre-established written criteria. There are healthcare organizations that they measure with their own compliance with standards and enhances the reputation of the organization in the eyes of the patient. It also differs by the type of program or service, as we've kind of already talked about. Now, there might be there is a different set of criteria and a different organization to accredit an outpatient surgery center than it would be for an acute care hospital or for a psychiatric facility or a rehab facility. Okay? Healthcare organizations that are accredited by an approved accreditation organization are exempt from routine state survey agencies. So if you go through this, used to, I'll back up and give you just a little bit of history. Used to, for instance, if you were accredited by the Joint Commission, which at that time was JACO, Joint Commission for the Accreditation of Healthcare Organizations, is what it used to be called. Then you also had to go through health department surveys, state health department, right? Well, in all the cutbacks, because they overlap in so many ways, they decided to kind of save time and money by agreeing to accept the accreditation standards of the Joint Commission. Okay? So but there is a process for them getting on that approved list and all that stuff. But I just kind of wanted you to know that used to you had to go through all these different ones, and now they've kind of teamed up, so to speak. So you don't have to go through as many, which may or may not be a good thing, right? But as long as they're covering and all-inclusive standards, that type of thing, then we're still achieving those goals. So an accreditation organization must go through its own CMS, that's the Centers for Medicare and Medicaid Services. I know it's a little deceiving. It kind of seems like it should be CMMS, but it's CMS. They have to go through their own CMS review to obtain deemed status, which is what I was talking about previously. And it evaluates the healthcare organizations for compliance with the communities of practice and the CFCs. The Joint Commission accredits a wide variety of healthcare organizations, and it continuously updates their survey processes and what they're looking for. And if you work in a healthcare organization, a hospital, or what have you, you definitely know about the Joint Commission, and if you don't know about it yet, you will, because they have continuous auditing, and they try to prepare everybody for what to expect and try to keep everything up to standard. And then they have mock surveys to go through as if they were a Joint Commission team member that was coming to survey the hospital to see how it stands. Okay, so, and to see where they need, their areas of improvement need to be. Okay, and the surveys are clinical and operational. They look at both components. It provides education to healthcare organizations related to compliance, so you can learn more. You can go to their website and learn more about the Joint Commission and what they require. The Joint Commission provides accreditation for ambulatory healthcare, behavioral healthcare, critical access hospitals. Do you know what a critical access hospital is? That might be something that you want to research. What is a critical access hospital? Home care, hospitals, laboratories, nursing care centers, physicians' offices, office-based surgery centers. And then we have state statutes that also provide standards. A statute is legislation written and approved by state legislature and then signed into law by the state's governor. It addresses the documentation requirements for specific types of records. The legal health record. You're going to use this a lot. It will always be debated with the changes in healthcare and documentation and different things like that. The legal health record is the documents and data elements that a healthcare provider may include in response to legally permissible requests for patient information. As you'll see, by the time you graduate, and you'll be going over this in numerous courses, just because someone submits a request for a copy of a record does not mean that it is a viable request. It has to meet certain criteria. And not just anybody can request someone's health record. And just because it's coming from an attorney does not mean that they get the entire record or what have you. Okay, so you have to know all the details and what to look for. And you will be provided with some training on that before you graduate, I assure you. The content of the legal health record varies from provider organization to another. It may be a hybrid record model. Defining the legal health record is difficult with health information exchanges. And a health information exchange is what they are aiming for is for us to have an exchange to where if you're admitted at UAMS and then you go on vacation to New York and you're admitted there, your physicians, if they're authorized and you give them the authorization, they could access your medical records from an exchange where all the healthcare organizations kind of deposit the records into a centralized location, okay, is a very simplified way of putting it. But they are working on something like that to provide continuity of care across all of the medical environments. So it could be a hybrid health record. Defining the record is difficult. You have to remember that we are only authorized to release the information according to the patient and according to that signed release of information requesting for certain information. However, if we also have copies of the patient's health record from another facility, we cannot release that information. They will have to go to that facility to get that information, even though we have it, okay? And that's going to be a whole other lesson. Continuing with the legal health record, a healthcare organization's EHR should serve as the legal health record. The policies and procedures should be established to define what its legal health record is. Exactly what do we include in a release for our legal health record? Okay? General documentation guidelines. They apply to all categories of health records. They're general. They're across the board, okay? And every healthcare organization should have policies for documentation guidelines. The they should be organized systematically to facilitate data retrieval and its compilation. So we need to know what those guidelines are so that we can have that health record in an organized manner to where we can retrieve that data when it's needed. Okay? Only individuals that are authorized by the organization's policies should be allowed to enter documentation in the health record. And it will specifically state who is authorized. Someone from Health Information Management, for example, is typically not authorized to document in the record. Okay? It really goes according, they have to specify exactly who can document. Maybe not by specific name, but by position and, like physical therapy or occupational therapist, the nursing staff, the physicians, the respiratory therapy. You see where I'm going with this? If it's not on that list, then you are not authorized to document in that record. Okay? So, then we have an organizational policy or medical staff rules, which is the bylaws, right? Medical staff rules and regulations should specify who may receive and transcribe verbal physician's orders. Okay? It will state who can do that. Another physician, a member of the medical staff, nurses. What level in nurse? Maybe it's only an RN. Okay? Can the unit secretary? Can someone from wherever? Who? It will state specifically who can take those verbal orders and write them down. Okay? Verbal orders may include a prescription. It may say, tell them to stop certain medication or start certain medication, or it might be ordering a radiology procedure or a consult or what have you. You see my point? Health record entries should be documented at the time of services, and they describe or rendered. For instance, if the physician sees the patient, then they write a progress note. If if occupational therapy sees the patient, they write a progress note. Okay, it should be documented at the time of service, either at the patient's bedside or shortly after, as soon as possible. Okay, authors of the entries should be clearly identified in the record. So if I were a physician and I wrote my progress note, I would sign it Karen K. Smith, MD. Or if I were an occupational therapist, I would sign it Karen K. Smith, OT. Or if I were a nurse, Karen K. Smith, RN. Okay, you see where we're getting at. Only abbreviations and symbols approved by the organization or medical staff rules and regulations should be used in the health record. Abbreviations can cause some problems. I mean, it's not going to do any good if the only person that knows what that abbreviation is the person writing it. Someone who's trying to code the record, if they don't know the abbreviation, if they can't find it on the approved list, then they're going to have to call and try to track down what it means. It can be dangerous. Maybe someone from another specialty, okay? One thing that comes into mind, I know at an organization that I was working at, we had urologists that saw patients, and respiratory. So one was talking about a respiratory infection, and one was talking about a renal infection, but they were using the same abbreviation. So I was like, okay, this is not going to work. I knew the two different services, I knew the two different physicians, and knew their specialties, but someone else coming in would not know that, or someone else following up, maybe a consult or in an emergency situation, if they didn't know that physician's specialty and saw the same abbreviation, it could be very confusing and life-threatening in certain situations, right? So we have to have an approved abbreviation list and symbols, because in health records we kind of have our own little shorthand sometime, and we all try to agree to use the same symbols so we can interpret things. Okay. And then all entries in the health record should be permanent, meaning they should only be documented in black or blue ink if they're handwritten. No pencil, not happening. Okay? No erasable ink, not happening. No whiteout, no corrective tape. If you go to correct a record and a handwritten record, you don't scribble it out. One line, strike through, and initialed, and the date. Okay? And then write the correct information. Okay? It's very important. Very important. Now, with an EHR, making changes, there's going to be processes to go through and certain steps that have to be taken to be able to make changes. You can't just go in there and change it, as we've already discussed. Any corrections or information added to the record by the patient should be inserted as an addendum. No changes should be made in the original entries in the record. Information added to the health record by the patient, we're talking about by the patient, should be clearly identified as an addendum. CMS, the Centers for Medicare and Medicaid Services, also has documentation requirements. All patient record entries must be legible, and we all know physicians are not known for writing very legibly. It should be complete, it should be dated and times. So if they wrote it on February 19th, 2019, it should say 2-19-2019, 3 p.m. or whatever. for that order, for the progress note, for anything that's being documented in the record, it should have a date and time, okay? And the initials or signature of anyone who's signing it, okay? So we know that it has to be legible, complete, dated, have the time, and authenticated in written. Authenticated means signed, okay, in written or electronic form by the person responsible for providing or evaluating the service provided, consistent with the hospital's policies and procedures. Okay, so if the physician is ordering it, the nursing staff may be authorized to take a verbal order, but that physician is still responsible for authenticating that order, for signing off on it, either written or electronically. Okay? And I do want to back up since we're talking about written orders or paper records, because if the computer system goes down, you have to be able to continue seeing patients and all of that. So you might resort to paper records if the system is down or in an emergency situation. Okay? So the reason why we do it in ink, for one, it's permanent, and we don't use other colored ink because think about if we need to copy or fax that in a situation to another facility, okay, a healthcare facility. Only the black or blue ink is going to show up, okay? And I can tell you from experience, I had one physician that thought he was going to be doing so good. He had a Sharpie that he was trying to find something to write his progress note with and used a Sharpie, and it just, you couldn't hardly read it because the lines were so thick. And so we had to make sure and clarify that also, okay? Authentication is you have to, it's identifying the source of the health record entry. It's a written signature of that person, or their initials, if that's approved at that facility, and it may be electronic signature. And CMS requires controls to prevent any changes from being made to the health record after the entries have been authenticated. If it needs to be changed, for instance, if it's been entered into the wrong health record, you picked up the wrong record by mistake and started documenting in it, and you realize, oh, this is the wrong patient. If it's a written one, you strike through error, in your explanation and leave it there. But you don't totally white it out, you don't erase it, you don't do anything. It's still, we've got to be able to tell it's a strike through. One line, okay? Electronically, we follow procedures for making corrections. Auto-authentication, when a physician or other healthcare provider cannot authenticate an entry that he or she cannot review. Documentation by setting. A health record consists of two types of documentation regardless of the setting. We have clinical and we have administrative, and we have talked about this previously, I know. Okay? So, if we're looking at by setting, the health record, depending on the setting and the media, will be organized a little differently. And the content, as well as the presentation of that content, will differ slightly based on the setting and the organization. Okay? So you might not find it, even though it's an acute care hospital, we can look at 3 different healthcare organizations, an acute care hospital, and you'll find little differences, maybe in the different order, different things like that. You know, it's not going to be identical from organization to organization. We've talked about that before. An inpatient health record. There's many services such as surgery, infusions, other diagnostic procedures that once required a patient to stay overnight in the hospital don't require the same level of treatment that they once did. For example, you might be in the hospital used to a week after you gave birth. Well, unless there's some kind of complication now, you typically go home the next day from the hospital nowadays. So things have changed. Some things that used to be performed as inpatient are now performed as outpatient, okay, and saving money there. Within the inpatient care services continuum, there are 3 major record types. We have medical surgical, medical/surgical, okay, obstetric, and newborn. Let's take a look at medical surgical. The medical surgical health record is found in a variety of settings. We have inpatient care units, we have long-term care health facilities, we have home health, we have surgical centers, we have ambulatory care centers. And health record documentation will pertain to adult patients with various acute and active disease processes or injuries. Basic acute care content, there's 9 components: medical history, physical exam, diagnosis and therapeutic procedures, the orders, clinical observations, diagnostic and therapeutic procedure reports. You know, you've got your orders, then we've got the clinical observation, then we have the reports of the procedures. Then procedure and surgical documentation, consultation reports, discharge summary, and then the patient instructions and transfer records. You have the patient registration information, which are the data elements that are obtained during the patient registration process. Remember, we have our uniform hospital discharge data set that we are required to collect, and then we can add additional elements according to our facility's needs. The patient registration information, we have the patient's full name, establishing or identifying an existing medical record number. the patient address, the patient's contact telephone number or cell phone number, should say, date of birth, the patient gender, the patient marital status, the patient's religious affiliation, the race, the next of kin information, the healthcare power of attorney or advance directives, if the patient has those, whether or not the patient wants to opt out of the healthcare facilities directory. Just because you're admitted into the hospital does not mean that you have to be listed in the directory. If you don't want to be listed in the directory and someone calls and asks you if you are in the hospital or for your room number, they can't confirm, deny, or give your room number, okay, without that authorization. The basic acute care content, when we're talking about patient account information, we're looking at the insurance payer information, insurance policyholder information, the patient's relationship to the insurance policy holder, whether it be the self or themselves, or maybe it's the husband or wife, or what have you, or maybe it's a child, okay? The insurance policy number is also important. Consents, authorizations, and acknowledgments. We're going to talk about each one of those in more specific, but consents would be consent to treat, for one, right? Consent for a procedure, consent to release information or to discuss their healthcare information with other members of their families or other parties, different things like that. The authorization to release the information, authorization, different things like that, the acknowledgments and all. Okay, I think we're going to pick up on special health records in the next segment, and give my voice a break and let you take a little break also, because we're on slide 37 and we still have roughly 21 to go, maybe 20, 21. So let's break off this segment right here at this slide, and we will pick up on slide 37 in our next segment.